We put out an associate position and we had over 120 applicants. I didn't select any of them because not one of them submitted a portfolio. Portfolio is number one, more so than letters. Whenever I restore a tooth, there's only one thing I can guarantee the patient, and that is no matter how good I am, and I am pretty good, no matter what I do, we'll fail. At every part of a patient's journey, there should be checkpoints where you start again. I think now is more important than ever. Improving dentist confidence, competence, and clinical skill, I think is more important than ever. The ideal treatment plan is made up of three things. If you're going to come in and work with us and be part of our team, and I'm going to trust you with my patients that I've built over 15 years and Sanjay for the last 25 years, I want to see what are you doing.
What is the craziest patient interaction you've had so far?
Within 2 minutes, he talked me out of buying a flat in my personal name. He explained to me within 3 minutes the tax implications. I then did exactly that and learned so much about investment through him. We need to work on our communication to get through that, because that is a fact. We sometimes need to replace crowns that other people have done.
Today, we're joined by a powerhouse in British dentistry, a clinician who spent over 15 years proving that you don't need to be a specialist to deliver world-class care. Dr. Nik Sethi is a general dentist who's mastered the balance between high-level clinical skill and the human side of our profession. From his early days being dragged to dental academies by his brother Sanjay, Nik has risen to become a respected leader and president of the British Academy of Aesthetic Dentistry, the BAAD. He's a passionate advocate for mentorship, minimally invasive protocols, and the often overlooked value of the dental trade. In this episode, we dive deep into the generalist advantage, exploring why embracing a broad scope of practice can lead to greater professional joy and better patient outcomes. We also get into the clinical essentials with back-to-basics occlusion tips that every young dentist needs to master to avoid failure and guarantee long-term treatment success, before uncovering the portfolio secrets which Nik specifically looks for when hiring new associates. Whether you're a foundation dentist or looking to level up your private practice, this is a masterclass in building a career with purpose. Let's get into it. So,
All right.
Dr. Nik Sethi, you have on the show today. How are you doing today, Nik?
I'm feeling good. Thanks for having me. I'm feeling very old sitting next to you both, though, I must say. I'm normally the young one in the room sitting next to my brother and Riyaz, so this is not a comfortable environment for me.
No worries. We're very glad to have you on. So for the people who don't know you so far, Nik, right, who are you?
I am a general dentist. I'm not a specialist. I love what I do. After 15 years, I think I'm more passionate about not just the clinical, but the industry of dentistry than I ever have been. And I enjoy all walks of life that come my way, and I enjoy meeting new people. And for me, I've never been driven by money. I've always been driven by connections, relationships, and helping people grow, and also growing myself. So I'm just a normal run-of-the-mill dentist that just tries to keep on improving.
Very humble words there. I'm sure you do a lot more than that, which we'll get into later on in the show. You mentioned that you're a run-of-the-mill dentist, right there, Nik, and you talked about how you're not a specialist. Can you talk to us a bit more about the value of being a generalist who's able to do many things very well, rather than specializing, and what kind of inspired you to go down that avenue of choosing a niche, of not choosing a niche and going super vertical on that?
It's a really good question. I'm not against either. I've got tremendous respect for further education. And if you know early on in your career, there's a particular discipline that you love, be it oral surgery via DCT pathways, be it endo, be it ortho, and you've got the discipline, go and do it. Go and become a specialist and set yourself apart and become one of the best in the industry. I'm all for further education. I guess I was heavily influenced by my brother Sanjay, who is one of these annoying clinicians that he's good at everything. He was incredibly, and still is, he's still around by the way, he's incredibly good at implants, restorative, endo, perio, and so I was kind of forced to do everything. And I was directed and got to meet some fantastic clinicians. I did so many courses, master's programs, year programs, individual courses. So I learnt to become fairly good at most things. And I enjoy variety. And that's not to say there's anything wrong with being a specialist in one discipline. Of course not. But for me, it would bore me just doing perio every day. I love the fact that 1 minute I'm doing an anterior composite, another minute I'm doing an onlay prep, another minute I'm doing a full mouth rehabilitation, then I'm restoring wear, and I've got an amazing team around me that can pick up the pieces that perhaps I don't enjoy doing so much, like complex second molar endos. I don't miss that at all. Ortho, I've got some great colleagues around me that do my ortho. I've got my perio specialists. I've got the implant guys. And so I get to pick and choose what I want to do. But the key thing is I've worked hard on making sure that I'm furthering my own skills. And I've also made sure I learn their skills as well. Because it's the common misconception when you refer to a specialist, you kind of leave the results in their hand and you kind of put specialists on a pedestal. I don't. I respect them for what they do. But if I'm referring a patient to a specialist, those specialists are working for me. They're under that patient's under my care. If I'm sending someone to Elaine for ortho or Sanjay to implants, it's part of my big treatment plan. They need to know what I expect of them, and their results need to be in line for me to then complete my work afterwards. So that's not to say that I don't still have control over that patient flow. I just don't necessarily have to do all of the pieces myself. So in summary, if you love doing a big variety, then stick to being general. Further yourself via either a prosthetic specialist degree or doing a diploma in advanced restorative dentistry, which we do a really good one. But there's several great educators in the market, of course, not just us. If you prefer doing one discipline, don't waste your time. If that's what you love doing, now's the time to get in, specialize, and be ahead of the game.
Understood. And you mentioned there that when you graduated, you went to BAAD and the whole world of these associations, right? How would you say that community had kind of shaped your career? And I understand you're now president of BAAD. So what is the reason behind why you chose to become president and go for that role? And what's the vision you have for BAAD?
So the British Academy of Aesthetic Dentistry, one of the main aesthetic academies, and I think one of the most well-respected in the world. Not the only great academy. We're very lucky. We've also got the BAAD. We've got several great academies in the UK. But BAAD is obviously very close to my heart because I've been going since 2011. Now, to prerequisite that, I didn't choose to go to BAAD. My brother, who was on the executive council at the time and is a previous president, he forced me. I was drag kicking and screaming because as any 22-year-old, to be honest, my priorities were let's go out and party. Although you guys are a lot more focused than perhaps I was when I first qualified doing ventures like this. I congratulate you. And Sanjay said, no, you're going to come to BAAD and you're just going to see what is possible in the world of dentistry. And okay, I wasn't looking forward to it that much, but I went, and within the first 10 seconds of being around the people in this room, I realized that I was somewhere special. Not people filled with egos. I was filled around people that were previous practice owners, specialists, advanced generalists, and they were just so happy to impart their knowledge, career advice, just great people, guys and girls that would really end up becoming some of my closest friends, not just in dentistry, but as a family. And that's just the people at the conference. But the actual lectures themselves were mind-blowing. The first lecture I saw was Didier Dietchi, who is one of my heroes in dentistry now. And I couldn't believe what could be done in composite. Now, your generation, you get to see a lot of this stuff on Instagram a lot earlier. We didn't really see it back when I qualified in 2009. But my word, his level of detail, his understanding, and just the results he were able to do with the same material I was using in practice and getting nothing of the sort of the result, I realized very quickly, oh, wow, okay, I need to really, inspire and aspire to be as good as these guys and girls. And through that, I also met some incredible friends in the trade who have helped shaped and supported me throughout my career. So it was an amazing family environment. It still is to this day. And every year, our mission is just to bring over the world's best speakers, not just in dentistry. We had an incredible Aura Max Fax surgeon, Dr. Nelson Leon from Venezuela. We flew him over. If you get a chance, get him on. He was wild, showing minimal orthodontic surgery. He's the only person I know that had the balls to treat Miss Venezuela and turn her into Miss Universe.
Wow.
Wow.
After some minimal orthodontic surgery. Incredible. But just every January, it's the perfect kick up my backside to get me refocused again for the year ahead. And just a great opportunity to catch up with some amazing people. So I thoroughly recommend it. I am biased as I'm the current president, but it is a fantastic academy. No egos. Forward thinking with a powerful hindsight.
Yeah. You mentioned being surrounded with people who are sort of like good at mentorship and inspire you. Do you think having a mentor throughout dental school and when you just come out is very important?
I think throughout your career, having someone to be accountable to, even if it's just a buddy that you're
Yeah.
going on courses with, that's fine. If it's someone that you go on a formal course, whether it be dental, or now I've, have like a business coach, for example, it's always nice to have someone that's more experienced in the field to help you when times are hard, show you what can be done, and also critically in our industry, help you through problems and problem solving if there's a case which you're particularly nervous about treating. We are treating human beings, and we're not expected to come out of dental school and be perfect. So for any student or first, second year qualified dentist, no one expects you to be perfect. Even patients understand when you're young, but what a patient and any principal expects is for you to be honest, caring, and have an ability to problem solve, or at least try hard to correct something if you've made a mistake, because mistakes happen. They still happen. So yeah, in answer to your question, I think it's vital. And I've surrounded myself with people that I don't compete with. I've weeded out a lot of people over the years that didn't make me feel good. And I surround myself with people that I can share great times with. But I also know at the drop of the hat, if I'm struggling with something, whether it be a case, a complex rehabilitation, I can call Riaz and ask for his help with occlusion. If it's a case planning implants and ortho, I can have a meeting with Sanjay and Elaine. Or if I'm just feeling a bit down because I haven't quite nailed a case and I've messed up certain things, I know I've got people around me that will pick me up and help me to fight another day.
So it sounds like community is very important within dentistry. You also mentioned, Nick, trade, right? And how it's often an overlooked part of the wider equation, right? How would you say you've interacted with trade, and how has that been for you so far? Any standout stories come to mind?
So the one thing I say is I think it's the most undervalued part of our profession. And honestly, I've learned off some amazing clinicians, but I've learned more about the industry of dentistry, and I've learned more about myself as a person and a communicator through the trade, sales representatives, material scientists, and various CEOs of companies than I have from other dentists. So going back to BAAD, and not all my stories are about BAAD, by the way, I was very lucky to meet who is now one of my dearest friends, not just in dentistry, but in life, David Altram, who is still with Henry Schein, and didn't know who he was at the time. And we were just discussing having a drink at the bar. And I was just, discussing my life, my health problems as a child and what I'd been through. He was discussing, we'd resonated on a few things. And he had an idea, said that, look, we'd like to document a diary of a young dentist and see the troubles you face. We'd like you to try some products, and the ones that you like, we can talk about. The ones that you don't, be honest about. It was never a pressure situation. And I was like, yeah, that sounds great. And I met Dave a few times, and it became very clear that Dave had a lot more to offer me than just me buying products from Optident or Henry Schein. What I learned from people, not just David Altram, but then through the wider Henry Schein network, people like Bao Chand, Petra, at the time, John Maloney, who was also with Optident back in the day, was their ability to communicate with people. And I actually offered my time just to go and help them on trade stands at the dental shows, for example, Birmingham Dental Show, BDIA, just because I thought one of the biggest challenges I faced as a young dentist when I was slightly fresher faced like yourselves is a patient trusting me. And if I was offering them, for example, private options over NHS, looking like a fresh-faced dentist with not even a hair on my chin, it was a hard one to convince a patient to convert. And I suddenly realized, hang about, when I go to these trade shows, these sales representatives are doing this all day, every day, and they have to perfect within a minute, 2 minutes, the art of communicating to gain a dentist's trust when there is hundreds of other trade stands next to them, when everyone's fighting over the same people. And I thought, if I can invest my time and just be surrounded in this environment, maybe I'll pick up a thing or two. I picked up way more than a thing or two. Just the way they're training, their level of understanding and what they've gone through to understand the products. We don't give them credit for how much they've put in to learn about each material they sell. It also taught me how patient they are, because dentists tend to have a bit of an ego on them. Oh, but I use this material because I heard this is the best. How do we handle those conversations? Same thing we face with a patient. Guy down the road's charging me £200. Why should I pay you £300? Similar concept we face every day. How do we set ourselves apart? How do we show the patients our value? And how do we establish rapport and trust in an environment where there is so much competition? So I'm so grateful to have spent time with people like Dave Altram, Bao, Petra, who I learn off every day. Have taught me communication, patience, the willingness to learn. And through that, I then got access from Optident sending me on courses to go and learn from amazing clinicians around the world. And then from that, I had a particular interest in light curing and adhesion. I got to meet some incredible materials scientists. I got to meet through Optident. I had the opportunity to fly out to Salt Lake City and spend time with the creator of the Velo, my favorite light cure unit. To this day, there is none better. I've done a ton of research on it, and I got to meet the creator of it, who made me understand one of the most underrated part of adhesive dentistry is the light. We don't pay attention to it, but actually the light is probably the most important part of setting that restoration. So I got to learn about wavelength distribution, beam collimations, size of the lens, the power. When we use a cheap knockoff that we buy from, I won't name a country, but any country, if we put that on a radiometer, what happens to the power? It jumps. It goes from 1,000 milliwatts to 10 milliwatts to 100 milliwatts. If we don't have a good wavelength distribution, are we fully setting our composite? It blew my mind. Then I got to spend time with material scientists on understanding bonding agents, self-etch versus total etch, universal versus single bottle, 2-bottle systems. It totally blew my mind. And again, it all came back to no dentist gave me that opportunity. Those opportunities came through friendships and being loyal to the trade. And to this day, you won't find me doing work with any trade that just pays me to. I work with just 3 or 4 companies that I always have done because of the loyalty they've shown me and because they have products that I've used for years and trust. So it's that two-way loyalty that I think is incredibly important, and I'm very grateful.
Awesome. So you mentioned the trade and the importance of working with the right companies, right? As young dentists, I understand in the early years of our careers, we might be constrained with the materials we have to offer, right? As we progress and become, let's say, more years at university and more self kind of guided in our approach, and as we become more experienced associates, would you say that the materials we choose as dentists are important? And by extension, how crucial are they in providing optimal patient care?
So we live in a time where most materials in the market are going to be good because of the vigorous testing and the process. And that's credit to the UK and Western medical systems and also amazing technology coming out through all countries and continents around the world. No company is going to be selling a product that is bad. That's not to say that all products are equal. I think what's really important, first and foremost, is as a young dentist, I'd go on a course where I was told to use I was using a certain composite or a certain instrument, a certain bonding agent. And I'd go back and be convinced that I won't be able to get the results for my patients unless I'm using those exact products. And so then I'd have fights with my practice manager. I need this, I need that cement, I need this. And actually, that was the wrong approach. It might be that those products were superior, it might be not. But whatever product you have access to in the practice you work in, the first thing you should do is pick up the manufacturer instructions. Actually read, not just because Nik Sethi or Afif or Yasmin said so, actually look at the manufacturer instructions to say, how long should I be etching for? How long should I be applying the bonding agent for? How long should I be light curing for? How is this material best stored? Should it be stored at room temperature? Should it be stored in the fridge? The quickest one, for example, is like temporary crown material. We all have this bad habit of squeezing a little bit onto our glove and then checking our finger when it's set. But actually, do we actually know the setting time? If we take off that temporary crown too quick and it further shrinks, it's not going to fit so well. We're going to spend a lot of time faffing around relining and restoration, where actually, if we just followed the instructions, we'd be streets ahead. Once you've mastered what you've got in your surgery and you're documenting with your clinical photography, if you're still having problems, then you need to look at a particular education course that will resolve that issue, be it anterior composites, posterior composites, onlays, endo, whatever it may be. Talk to esteemed lecturers or professionals in that environment. They might then be able to say, actually, do you know what, that material, in my opinion, read these papers and perhaps that's why you should look at switching. So over the years, I've only ever switched materials, not just because someone told me to, it's because I've gone and done my research on it. It's very difficult for someone to convince me to use something new until I've seen good data, read around the topic. And that's why, again, speaking to the trade representatives is incredibly important because they really understand the materials, but it's equally important to then go away and do your own research on it before you just start using something new.
Understood. That's a really empirical approach I think we should take forward as we realize that the materials we're using can actually impact long-term prognosis. And having that kind of data-driven approach, I think, is really, really insightful. So Nik, let's get clinical, right? I understand you're an educator, you're someone who's been in the industry for a long time and has learned the lessons, right? You're also very keen to educate young dentists. Now, I'm in my second year of university. I know occlusion is a very important topic, right? I've not learned occlusion yet. So what would you say the foundational things you should know are that you should know as a dentist about occlusion? Because oftentimes we hear that university is not taught the best.
So I was very lucky in 2018, 17 to meet Professor Riaz Yar, who has been a fantastic mentor for me and one of my fellow founders of Elevate Education. And I was in the same boat. When we first qualified, I don't think hardly anyone actually understands occlusion. And it's about breaking it down into basics. It's something Riaz taught me. Understand your basic armamentarium. So what articulating paper are we using? What are we looking for when we get the patient to tap down? Yeah, we see these colours on the teeth, but what does it actually mean? How do we know when we've got an actual contact or what we call a smear? So, for example, we think of articulated paper as some magic, super expensive material. For those of you listening to this that are slightly older, your parents probably used carbon paper when they were doing their accounts back in the day. And all articulating paper is under pressure, it will transfer colour to whatever is underneath it. And that's what we used to do. That was old school copy. I say we, I'm not that old. That's what my dad used to do before we had a photocopier. And that's all articulated paper is. Under pressure, it will transfer colour, but it will also transfer colour with moisture. And what's the mouth got loads of? Moisture. So when you get the patient to tap down, what we don't always know is if we've got a true contact or a smear. And a smear means it's been coloured via moisture. So the first thing we need to look at is how are we drying the teeth before we get the patient to tap down? Because if we're just using a 3-in-1, which we all do, we're just blowing saliva from one tooth to another, and it's not accurate. So Riaz taught me that I always have 2 Miller's forceps on my checkup tray or my treatment tray. One has got my articulating paper and one has got tissue. So I get the patient to bite down on the tissue, and as soon as that comes out, the articulated paper goes in. So I'm only recording the true contacts, and we're removing the inaccuracies of a smear. At that point, I still need to understand what contacts do I ideally want to see. And typically, we don't often see it. In the textbooks, we're taught we want to see contacts on a cusp tip, a fossa, and a marginal ridge. Typically, we see it on one of those 3. If we're lucky, 2. That means when we restore a tooth with a composite or an on-layer or a crown, the mistake most of us make is we check the occlusion at the end. And if we're doing single tooth dentistry, the only way we can know if we've truly conformed is if actually we know what we had at the start. So it's just as important to take the occlusal record at the start of the appointment as it is at the end to see have we actually given back the patient what they started with. The next thing is understanding the use of shim stock, 8 microns. And again, taking your shim stock hold before you treat the patient and after. So, you know, those cases again, sorry, Riaz, I'm literally stealing your whole lecture here. He won't mind. Is those patients where you mark with articulated paper and everything looks even, but the patient still says, Doc, I think the restoration is still high. And we say, yeah, you'll be all right. Just give it a few weeks. Actually, 9 times out of 10, they're right. And the only way to know that is articulated paper will get you down to a certain thickness based on the thickness of that articulating paper. So we have articulated paper that's really thick, like the denture stuff, 200 microns. Don't use that for restorative work. You want to use a nice 20 to 40 micron thin articulating paper, which is much more accurate. That will get you very close. And then to confirm if your occlusion is right, you need to see at the beginning of your appointment which teeth tug with shim stock and get your nurse to write that down. So if I'm restoring an upper right 6, I will test my shim stock holes on the 5, 6, 7 and one tooth on the other side. And I will say to my nurse, shim stock holes, upper right 5, 6, 7, upper left 6, if it's all holding. And then the only way to test if I've truly conformed is after I've done my restoration and I've adjusted it with articulating paper, but the patient still thinks it's slightly off, I check my shim stock holds again. And lo and behold, it's probably only tugging on that 6, and there's probably no holds on the 5, 7, and other 6, which means the patient was right. So wherever it is marking on that tooth, I then need to adjust all of those points very slightly until I can check my occlusion and confirm I've now re-established shim stock holes 5, 6, 7, contralateral 6. That's a much better way of finishing your notes, something Riaz always says, rather than just say what we all say on our notes, occlusion checked. Because what does that mean?
I'm sure lots of insights there. If people listening, you might have re-educated people on occlusion. What are your thoughts on TET scans? I know T scans are a big thing over in the States. How do you think they compare to articulating paper? And do you think there'll be a more widespread adoption of that technology in the years to come?
I think we're moving in the right direction with technology like that. You need to get Riaz on the show to be asking himself that. That's totally his bag with T scans, mod jaw, dynamic recording. I mean, it blows my mind some of the stuff Riaz talks about. But essentially, you're being able to see where that force is distributed, which is really important, especially if we're doing rehabilitation in dentistry and we're doing several failing restorations and we're reorganizing occlusion. Then I think the more technology we have and data and scanning and things like modular, I think it will be the future. But make sure you definitely get Riaz on because
on the show for next season.
On that. Yeah, 100%.
So, I mean, I feel like I'm on a course right now. This is amazing. It seems like you're very passionate about educating other younger individuals and dentists. Do you think this has inspired you with your course and making it? And do you think you want to continue teaching and educating the younger?
I'm 5 years in. I've dropped down to 2 days clinical, so I hope I still enjoy it. Yeah, I'm moving in that way. Yeah, I think now is more important than ever. That as clinicians qualify, unfortunately in this country, due to the heavy processes, in my experience, correct me if I'm wrong, but clinicians that I see that I'm teaching every year are qualifying with perhaps slightly less clinical experience than we had in my time. And certainly I had less than what my brother had in his time. So I think this is a generational shift that we're doing less and less and relying on more work on models. And so the need for improving dentist confidence, competence, and clinical skill, I think is more important than ever.
Absolutely.
In a time where all of you are faced with this barrage of crap on social media and you're constantly comparing yourself to people you shouldn't be, that are showing you their day one results, what I did this morning, and putting posters up on Instagram, unless someone is showing you 6 months, a year, 2, 3, 4 year reviews, delete them, get rid of them. Get rid of the people in your life that don't make you feel good. My point is you're going to face a lot more competition or perceived competition. A lot of dentists are qualifying with a lot less clinical experience and confidence. And so I was extremely lucky to have my brother who, didn't give me a choice. He mentored me and hammered me into the person that I've become. Introduced me to BAAD, where I got to meet people like Dave Ultram, Rob Aretti, Daniel Flynn, Tiff Qureshi, you name it. And I consider all of them as incredible friends. Then I got to meet people like Elaine Moe, who's one of our founders of Elevate, and she was 4 or 5 years younger than me. And I did the same to her that my brother did to me. I mentored her, took her under my wing. And no matter where she was, where I was in the world, every Tuesday we'd jump on a Zoom call and she'd show me every case she'd done at Square Mile that week when she started working at the practice. And she took on everything I said, every bit of criticism, and I was hard on her. And now she's doing work that's incredible. She's one of our lead lecturers and she's lecturing all over Europe with us and she's absolutely amazing. And so I think having seen people younger than me grow and knowing that I've had a small part to play in their progress, knowing how lucky I was, I think it's more important than ever that we inspire that next generation. Otherwise, as I mentioned when we were chatting downstairs over coffee, you're in the education system from the age of 4 years old. And you're in there for 18 years up until you finish uni. And we're not spoon-fed, but we are structured and directed. And then suddenly you finish your FD and it's here you go.
Yeah.
What do you do then? And the answer is if you don't have anyone at least showing you the way, or you don't electively go into structured education, it's very easy to fall out of love with dentistry. And you see it all the time. I see friends of mine from university who were incredibly bright, much brighter than I was at university, and they just don't have the love for it anymore. And I find that really sad because I think we're one of the few professions left that is safe for now. And our ability to help and transform patients, our understanding of bacteria in the mouth and how that can impact their general health on perio disease and the impact on heart disease, diabetes, blood pressure, Alzheimer's. We now know that we are much more than just tooth doctors. We are incredibly important when it comes to systemic health and preventing future disease.
Yeah.
And so if I can have a small part to play in helping young dentists as something Drew Shah says, light the fire, then I am definitely going to continue that, and I'm going to double down on it, which is why I'm reducing what I'm doing clinically to help grow on the education space, because that is really my North Star.
What do you think your top tip is for students going into FD training on how to do a good treatment plan that is not too difficult but good and refined?
So something we always teach on the Elevate course is, it's quite a broad question, is the ideal treatment plan is made up of three things. Again, Riaz. Riaz and Sanj always helped me a lot with my treatment planning when I was younger. And it's about understanding the patient desirability. What do they want? Their affordability. What can they afford? And their suitability. Is the proposed treatment plan, what you'd like to do, is it suitable for their mouth? Meaning a patient might come in and say, I want composite bonding, but they might have unstable periodontal health.
Yeah.
They might have gross caries on posterior teeth. They might have abscesses. And as young dentists, patients will try and pressure you. I had it all the time. Oh, yeah, I'll come back to that later, but I'm getting married in a month, so can you just whiten my teeth and fix these edges? And I always say to them, well, you didn't just propose today, did you? I'm guessing this wedding's been in the mix for the last 6, 7, 8 months.
Sure.
It's not my fault you're getting married in the next week. I've got a due care of process to understand, are you suitable for the treatment that you're desiring? And so in answer to your question, you need to have a really robust examination process. Even in a 15-minute NHS exam, you should be able to have a really good, robust treatment plan that gets them stable. Meaning, in that 15 minutes, I might not be able to plan all their aesthetic work, all their veneers, their dull and their restoring wear. That's not possible. I, to this day, can't plan an aesthetic case in 15 minutes after an exam. But what I can plan in 15 minutes is understanding, do they have periodontal disease? Do they have active caries? Are there any teeth which are failing and require extraction? Are there any teeth that require endodontic treatment? So I can plan that patient very quickly for a phase 1 to get them dentally fit and stable. That's all I can promise the patient. And what I say to my patient is, once we achieve these initial objectives, here's some of the work I can do, because you've asked me about improving my smile. And I show them cases of whitening, anterior composites, posterior composites, crowns, veneers. I said, but when we get to that checkpoint, I'm then going to need a 45-minute or an hour assessment where we can then plan that case properly. If a patient says, but roughly how much is that going to be? I say, it's impossible to give you an exact figure, but I've done enough of these cases to know it's going to be somewhere between X and Y, and I will give them a massive range. I could say somewhere between 800 and 5 grand, because you just don't know at that point. It might be somewhere between 10 and 25 grand, because all you can do for that patient at that initial visit is plan their basic dental health, which we all know and we qualify ready to do that. As young dentists, we put far too much pressure on ourselves because we're seeing what other people are doing on Instagram, trying to plan an aesthetic case as well as everything else in that 15-minute appointment. It's impossible. Something I learned off an amazing Italian clinician, Stefano Grazzi. We had him speak at the British Academy a couple of years ago. And if you get a chance, go to Italy, do his course. He's one of the best out there on treatment planning. And he said, at every part of a patient's journey, there should be checkpoints where you start again. So that patient might come in not being so aesthetically focused at the beginning, but as they get to trust you, learn about you and how caring you are, their aesthetic demands may change throughout that process. So once you've done that phase 1 of caries stabilization and perio stabilization, you almost start again as a brand new patient, and you ask them the same question that I ask all of my patients, 2 questions. The first one is there anything you're worried about the health of your teeth and gums? And secondly, I give them a mirror and say, is there anything you would change about your smile? Please tell me, and feel free to say nothing. And then I'm asking them a question about health and a question about aesthetics. And once I've done that initial plan and we've completed the stabilization, I will ask them the same questions again, and then I'll have more time to do a more detailed assessment. If it's part of a larger full mouth rehabilitation, the next phase might be doing several composite restorations, maybe a few endos. Once that's done, we'll reassess them again, almost like a new patient, see how stable their occlusion is, how deep is their overbite, and before we start doing the anterior ceramics or composites, Do we need to look at possibly some aligner therapies to correct the occlusion? Do we need to build up the backs of the teeth to give myself a less overbite to create space to add? So at each point, I'm not trying to blow my mind with planning everything because there's so many variables
Yeah.
at the beginning. Does that kind of answer your
Yeah,
question? It's a
absolutely.
big question you asked there, but
Mm.
hopefully that gives some insight on
It
it.
was great, thank you. I think more than ever now we're moving towards minimally invasive dentistry. For our audience, could you expand a little on that and what your thoughts are?
So there's two phrases there I think are important. Minimally invasive is one,
Mm.
which technically, if we take the definition, it is to do the least dentistry possible on a patient, the least damage to a tooth
Yeah.
possible. But there are certain times where we need to look at something that Didier Dietschy says, minimally hazardous dentistry,
Mm.
meaning sometimes it might not be the most minimally invasive procedure, but it's in the best interest for the longevity of the patient.
Yeah.
So to backtrack a second, whenever I restore a tooth, there's only one thing I can guarantee the patient, and that is no matter how good I am, and I am pretty good, no matter what I do, will fail. Sorry, it's going to happen. But the one thing I'm trying to do is make sure that I cause the least damage to your tooth now so that the next clinician, be it myself, be it Afif, be it Yasmin, has enough tooth structure to go again when this fails in 10, 15, 20 years' time.
Yeah.
That means as long as I've planned you comprehensively, if I can veer towards a minimally prepped onlay versus a traditional crown, then over the next 15 years, if I've got a minimal prep onlay, I've got total access to see what's going on around that tooth. Let's face it, when you see a crown on clinic and you're assessing it as an exam, you don't really know what's going on underneath.
No.
And you take an x-ray, and until that decay is large enough that it shows up, which means it's really bad underneath, you don't know what's going on.
Yeah.
And then you've got that dreaded situation of trying to explain to a patient, we're going to remove this crown, which might not be causing them pain because I can see decay. The problem is I don't know if it's going to have an infection later and I might need root canal treatment. I don't know if I'm going to have enough tooth structure to save the tooth. It's not a nice conversation to
No.
have. We need to work on our communication to get through that
Yeah.
because that is a fact. We sometimes need to replace crowns that other people have done. But if I'm able to just do 1.5 millimeters reduction and do a minimal prep onlay, something that we teach lots of at Elevate with our course FIPO, functional indirect posterior onlays, it's hardly any more destructive than an MOD composite.
Mm.
But I'm able to have a complete 360 view of that tooth
Yeah.
so that if there is some marginal caries, I can reseal it. And in 15 years' time, if the restoration fails, I can then move to a crown because we know the average lifespan of a crown is 12 to 15 years.
Yeah.
So if that patient's 20 years old and I put a full crown on, then Daniel Edelhoff and Sorensen have shown us in 2002, when we do a full crown, we lose 60 to 70% of the volume of tooth structure. That's not small. That's massive. 60 to 70% of the tooth structure. If that crown lasts the full 15 years that the studies tell us, that patient's only 35.
Yeah.
If that crown fails irreversibly with extensive caries and needs an extraction, they then need an implant or even a post-crown at that point if there's just about enough structure. But let's say they need an implant. Average lifespan of implant, 10 years.
Mm.
They're then 45. How do we then replace implants predictably? Not so easy. Lots of grafting. You're talking thousands of pounds and lots of complicated surgeries even before the age of 60 years old.
Mm.
So the earlier we can look after our patients via even before the onlays, let's go right back a second. As a dentist, we have a duty of care to educate our patients on what they're putting in their bodies.
Yeah.
Something that Tif Qureshi has taught me. We need to be looking at getting our patients blood tested to look at their HB1AC levels. How controlled is their diet? Anyone with more than 1 or 2, 3 caries lesions, they need to be doing a full diet sheet.
Yeah.
I need to see how much refined sugar are you putting into your body, because yes, I need to do some dentistry now, but everything's going to fail unless you change now what you're doing. And not just for your teeth, but for the rest of your health. So if I can have an impact, myself and my hygiene team are so undervalued here. Hygiene therapy, I think, are most important in the dental profession.
I agree.
They set the tone, which dentists don't see as important. And it's wrong. It's all about things like saliva testing, diet advice, prevention protocols, minimally invasive treatments such as, curodont repair, fluoride treatments. What are we doing to lower the caries risk? That's first thing. Secondly, if there is caries, how can we use modern approaches like Avik Banerjee talks about with Edwina Kidd principles of selective caries removal to reduce the risk of endodontic treatments, using newer universal bonding agents and avoiding etching dentine, and using a selective etch approach on the enamel instead to reduce post-op sensitivity. But if there is certain criteria met, so if my cuspal thickness is less than 1 millimeter in a vital tooth, or there's a crack in the tooth or previous endo with an MOD, and I need to think about cuspal coverage, how can I avoid a crown via a minimal prep onlay? And I'm only going to consider a full crown if I'm replacing an old crown, if I've got a dark non-vital tooth for aesthetic reasons, or if there are structural concerns where perhaps I can't isolate a tooth for rubber dam isolation for adhesion, then I will consider a full crown. All of those steps in a row will contribute to being minimally hazardous or minimally invasive and buy patients that time. If I can buy them 15 years, that's 15 years before the rest of that cascade happens.
Understood. So it's more than just a kind of an approach, it's more of philosophy. And it's kind of having that long-term approach towards patients, not just seeing them as they are now, but who they will be in decades from now, which is really, really insightful. Let's zoom out for a second. We've got really clinical there into the nitty-gritty. I want to ask you, Nik, what is the craziest patient interaction you've had so far?
Say that again?
What is the craziest patient interaction you've had so far? Anything which is really memorable?
Yeah. A couple which I probably shouldn't say.
Okay.
There's some really interesting ones. I'll tell you a great one. I mean, I've always really enjoyed understanding my patients, and especially in London, we met some fantastic people. I became really good friends with a chap called Nick and his then fiance, now wife, Anna. And we just resonated on so many levels. When you actually just start talking to your patients and we just slow down the factory a second, it's amazing the stories you get. I learned so much from him. He within 2 minutes, he talked me out of buying a flat in my personal name and advised me on how to set up a limited company and turn it into a special purpose vehicle and buy it there. He explained to me within 3 minutes the tax implications. And because of that, I then did exactly that and learned so much about investment through him. He became a really good friend of mine. I was one of his ushers at his wedding. And when me and my wife went to party in Vegas in 2019, him and his wife flew out and joined us for a couple of nights. It was great.
Oh, wow.
So we became really good friends. I learned so much from him. We obviously looked after him and his wife. Just some beautiful relationships. So that's one crazy in terms of the partying in Vegas, and also the fact that I got some sound investment advice in 2 minutes when I was in the middle of doing his exam.
Yeah.
He was like, stop. I need to tell you about this. Like, okay, wow, brilliant. So yeah, that's one of them. That's probably one of the more kind of innocent stories.
One of the table ones, fair enough. That's really interesting. So I guess as dentists, we see a range of professions. So maybe get some advice where possible as well, if you can build that rapport. Awesome. So Nik, I understand you're also a principal at 2 locations in London, right? What do you look for when hiring a young associate?
This is a really interesting one. So I am partner with a dental beauty practice in Essex, in Dental Beauty Basildon, which I'm very proud about. I also run all the education for Dental Beauty Group, and they've built something incredible there. We work with most of the DSOs actually, so I'm very proud to have a position with that. And I own a private practice with my brother and a colleague, Amit Patel, Square Mile Dental Centre, which I've been part of since its inception. When my brother bought it in 1998, but I've been working there for about 14 years. And I bought into both practices during lockdown. I would not recommend buying 2 practices at the same time. That was incredibly stressful. And Square Mile Dental Centre has always had a really good reputation, and I'm very grateful for that. And we've always been very strict with who we hire. We put out an associate position, I think 3 odd years ago, and we had over 120 applicants for the position, which was great. Yeah. Really humbled. Of that, at least 20 or 30 of them had specialist degrees. And of those, I didn't select any of them because not one of them submitted a portfolio. It was just letters after letters after letters. And I told you from the beginning, I'm not a specialist. So letters I respect, but letters alone don't mean anything to me. I need to see what you're about. If you're going to come in and work with us, and be part of our team, and I'm going to trust you with my patients that I've built over 15 years and Sanjay for the last 25 years, I want to see what are you doing. That doesn't necessarily mean you to be the best clinician in the world, but I want to see that you're following the right protocols. You're honest to see where you could have done better. So in answer to your question, portfolio is number one, more so than letters. That's not to discount education. I've done a lot of further education, but documentation is so important. Photograph everything. As clinicians, we have a bad habit of taking photos at the beginning, taking a photo during, and if the composite doesn't look good, we say, oh yeah, we'll take the photo next time, and we don't take that photo. Actually, the case that didn't go so well is the most important photo to take, because that's the one you can go home and pull up and understand where did it go wrong, or ask colleagues. And gradually, as you learn your own mistakes, that's your most powerful CPD you can have, is learning off your own failures, you will start to have more cases that start to go well. And it might just be something simple like whitening. So something that I learned from Optident, 3 presentations on my iPad when I'm trying to convert private work: a whitening case, an anterior composite case, and a posterior composite case. And then I extrapolated that to include onlays, veneers, crowns, and now there's hundreds of cases. That was enough for me to be able to talk to a patient and help them understand the difference between the private and NHS options, the outcome of whitening with modern systems and good trays. And it was also, I didn't realize at the time, it allowed me to then have a chance to then work at private practices, and it allowed me to have a chance for my brother. My brother didn't take me on for the first 4 years. He didn't trust me, or about 3 years, because he wanted to see what I was doing. So any clinician, you should be documenting, organizing your portfolio, good photos. Go on a photography course as soon as you can. Invest in loops, invest in a good camera setup. And when you start documenting, putting your portfolio together, try and get a nice array of general dental procedures: whitening, anterior composite, posterior composites, crowns, onlays, so that when you go to apply for your next position, you can show your principal, proposed principal, what you're able to offer immediately in your clinic. And that will jump you right above to the top of the pile. And we actually took on a young associate because his portfolio was excellent, a chap called Ankit Shah, who's still with us now and doing fantastic things in the education space as well. Really, really good guy, great clinician, and good ethos, good values. He's one of us, great guy. So yeah, portfolio is one of them. Attitude is another big one. I don't want to know it all. I don't want the next celebrity dentist. I won't name the names, but you know the ones that are the celebrity. I don't want them in my practice. The ones that are going to be divas. I want the people that are going to be treating my reception staff with respect, educating my nurses if they've got protocols that are different, not just demanding. How are you bringing along the rest of our profession with you? If you're going to go on a course tomorrow and come back and demand your nurse suddenly puts out all of this extra equipment, well, they're not getting paid any more for it. You might be, but they're not. So what are we doing to empower them? How are we bringing them along with the education? How are we thanking them better? How are we making them feel special? If you want someone to work hard for you, what are you doing to make their day better? So I want to see an associate who treats people with respect. The minute they walk through the door, how are they welcoming themselves? How are they introducing themselves to the reception team? How are they treating the nurses? Are they making conversation while they're waiting for me if I'm running slightly late, or just sitting up there on their phone looking at Instagram? How are they going to jump to the top of my pile? And that's portfolio, attitude. And once they do start, it doesn't always work out. I've had 1 or 2 that didn't work out, and we've realized very soon after. It's that commitment. It's that willingness to show me cases. Don't just hide away and don't show me anything. Be willing to take the critique. And again, rather than just be demanding about what materials you want, read the manufacturer instructions and get the best of what you have first. And if you can show me over 6 months, a year, that you are producing some really nice results, if you're able to generate a profit, which a lot of associates don't, by the way, if you're able to generate a profit and you're showing me commitment and respect to my team, well, then if you want that new shade of composite or want that 50 quid instrument, I won't even bat an eyelid. Go for it. It's yours. Elaine doesn't even have to ask me now. Whatever she wants, just whatever, just get it. It's cool. She's got way more kit than I have. But it's that old school loyalty, respect, willingness to document and show your work, and having the humbleness to improve. And there's, unfortunately, I'm seeing not as much of that as perhaps from a few years ago, but I'm very lucky that people we've taken on, not just in London, but all of my associates, shout out to Dental Beauty Basildon, we've got a phenomenal team there as well. They are so good and they help each other out. And if there's a problem with someone's emergency, everyone will look after each other. That's the other thing. If a crown's come off, temporary crown's come off, it doesn't matter. If you have to see someone else's patient, who cares? Get on with it. Help them out, because one day your temporary crown will come off.
Understood. That's really insightful, Nick. I think over the past 50 minutes, you've got a really good understanding of your clinical approach, your approach to patient care, and kind of the different various parts of dentistry involved with an educator, principal, and associate, and a clinician rather. I want to ask you then, with that all in mind and with that all in consideration, what does success look like to you today?
In dentistry or generally?
As broad as you like.
Success for me is being happy. I've never been money driven. I've been lucky that we've done well. Probably not as well as a lot of my colleagues that have been more money driven than me. But I've got a beautiful wife, I've got amazing 2 kids. And success for me is knowing that despite being very busy and traveling a lot, I am 100% dad when I'm home. Pickups, drop-offs, family holidays, getting better at putting our personal time in the diary first so I can spend more time with my wife. Love my relationship with my brother and his family. I see his kids as my own. So grateful to my parents. Success for me is being happy, being grateful, being a dad, being a loyal, caring person in my family. Forget everything else. Look, I've spent the stupid money on cars in the past. I don't do that anymore. I've spent the stupid money on a watch. Still have that watch. But none of that matters. None of that matters. Waking up and knowing that I'm giving 100% to inspire the next generation. When I'm in clinic, I'm giving 100% to do the best I can for my patients. I'm not saying I'm the most organized principal in the world, because I'm not. I'm not saying I'm the most organized person in the world. I definitely am not the most business-minded professional in the world. But hopefully anyone that's worked with me as a team member, nurse, receptionist, practice manager, or a dentist can never say that I've done them wrong. And so success for me is knowing that I've never knowingly done someone over. Something Drew taught me: never compare yourself to people. Be inspired by the fact they've got more people at their stand than you have at yours. What can you do differently without compromising your values? It's great. That keeps you inspired. And never forget the people that mean the most to you in the world. Your family, your friends. And I am guilty of not spending enough time with my friends, and I want to be better at that. Random acts of kindness and making more beautiful memories. We're taking 3 months off in the summer. We always said we'd do it for my 40th birthday. Me, Nisha, and the kids are going to go live in Thailand and Bali for the summer.
Whoa, okay.
Yeah,
Lock off from everything
it's amazing.
and just create memories while the kids are young. I was very lucky that I don't have the typical Asian background. I went on a leadership course, Samir Patel's leadership course, which was really good actually. I enjoyed it. And the first task was everyone had to map out their, sorry, it's a long answer to a short question. The first task was everyone had to map out their journey of why they are here today. And generally amongst the Asian colleagues, it was always the same story. Hardly saw dad. Dad was away working and I spent most of my time with my mum. And they all did what they had to do. I was an anomaly that, I don't know how my dad did it. He somehow built a property portfolio. He was a senior tax advisor for the HMRC. He used to sell car parts. He was incredibly organized and so good, very entrepreneurial, way ahead of his time. But he never missed a school pickup. He never missed a school play. It made me emotional to think about, actually. I don't remember a time growing up when my dad wasn't there. And so for me, success would be if I could give the same thing to my kids that my dad gave for me.
Well, so staying true to your values and being present with people you care about. Awesome. Thank you very much, Nick. It's been an absolute pleasure.
Cool. Thank you so much.